today is to tell you about the ABC of abdominal imaging from X-ray to MRI. So let's start. So what are the objectives of our today's talk is that by the end of this session, you should be able to name the common modalities which are used in the gastrointestinal or the GIT imaging, and you should recognize the normal anatomy on different imaging modalities. I'll be showing you one or two slides about a very common pathology, but my emphasis is basically to tell you how the normal imaging looks and for what diseases you should ask for what modality. Okay, so basically abdominal imaging can be divided into two, like we've got the hollow viscera, that is the GIT, and then we've got the solid organs. I have not included the kidneys and the reproductive organs in this presentation. So the hollow viscera, as we all know, that the GIT extends from the mouth to the anus, and it's got the oropharynx, then we've got the esophagus, stomach, small intestine, which has got duodenum, jejunum, and ileum. And then we've got the large intestine, which is also known as the colon. So we've got the ascending colon, the transverse colon, descending colon, sigmoid colon, and the rectum. Okay. Okay, so the solid organs we know: liver, spleen, gallbladder, and pancreas. Now coming to the imaging modalities. These are more or less the imaging modalities that every hospital uses, ranging from the X-rays, then ultrasound, fluoroscopy, CT scan, and MRI. So I think everybody of our radiology colleagues, we know who this gentleman is. His name is Wilhelm Conrad Röntgen, and he's the one who accidentally discovered the X-rays way back in 1895. And he was, playing with the radiation, or he was experimenting, and suddenly he saw how the image was formed. So that is why the X-rays are known as X-rays till date, although these are the electromagnetic waves, now we know, but we call them as X-rays. So this is a typical X-ray machine. I hope you can see my cursor, my mouse, this arrow. So this is the couch, this is the X-ray machine. From here, the X-rays, they go down, they pass through the patient, and here is the cassette, which is lying behind the patient. Nowadays, most of the sophisticated hospitals, they're using the DR, the digital system, in which there's no need for an image receptor. But this is how the things work over here. At my hospital, we have got 3 of these conventional X-ray machines and 2 of the DRs. So just wanted to show you. Then a little bit about the physics, just a little bit how the X-rays, they're really forming inside the X-ray tube. So what's happening in the tube, you give a certain kind of voltage and current to the tube, and then the X-rays electrons are emitted from this cathode. They strike the anode, and then you get the X-rays. So this is a little bit about the physics. Now, this is the most important slide in my opinion, because on an X-ray you see some black, some white, some gray, some off-white. And if you know why you are seeing certain pathologies or certain normal organs as black and white, then it would be very easy for you to go to the diagnosis. So the thing is, when the X-rays, they pass through your body, there are bones in the body, there are organs like liver, the kidneys, the lungs. So the organs that absorb the X-rays, most of the X-rays, they appear as white. This is the basic principle. And the organs through which the X-rays, they all pass, they appear as black. So the lungs, as we know, the lungs are full of air. A normal lung has got air. So when the X-rays, they pass through the normal lung, it appears black on an X-ray, whereas the bone has got a very high atomic number and it absorbs most of the X-rays, hence it appears white on an X-ray. Just to give you a practical example, this is an X-ray chest, the most frequently ordered investigation. And here you see that the ribs are white, the clavicles are white. Why? Because the bones, they've got a high atomic number, they're absorbing the X-rays and they appear white. Whereas the lungs, see, they're black because they're normal lungs. So the X-rays, they pass through them. If there was some pathology over here, like a mass or an effusion or a consolidation, it would have absorbed some of the X-rays and it would have appeared white. So this is the basic thing, because people, especially the medical students, they're really confused in the beginning why we are seeing certain things as black, why we are seeing certain things as white. So this is a normal abdominal X-ray, abdominal radiograph. You take in 2 positions. In an AP erect position, the patient is standing, and then you take a supine position in which the patient is lying down. I'll tell you why we take 2 views. So this is basically a supine view, sorry. Here you see, this is the lumbar spine, the pelvic bones, this is the pelvis, and the femur. And here you see there is some black opacities, black things you are seeing over here. So what is it? As I've told you, the air appears black, and we know that in the normal intestine, in the large, in the small, and the stomach, you should have some sort of a normal air. So this is the normal colon that you are seeing, right? So if you don't see any air in the abdomen, then you should be alarmed because something is wrong. So you have to see some kind of a normal air in the small gut loops, in the large gut loops, and also in the stomach. So this is another radiograph of the abdomen, supine radiograph. Here you see the air is seen in the stomach. Some air is seen in the colon as well, some here in the gut loops. So this is how a normal radiograph looks like. Another thing, we also see the shadows of certain organs, like because it's a 2D thing, two-dimensional, you can't see the liver properly, but you know that this is the area of the liver under the right hemidiaphragm. And if you see, if the patient is very lean, if the radiograph is of a very good quality, you can see the border. See, this is the lower border of the liver. This is the area of the kidney. This is the psoas muscle outline. Here again, as I've told you before, air in the stomach, air in the colon, air in the small gut. So this is how a normal X-ray abdomen looks like. Just as I've told you, I would be showing you only 2 images of intestinal obstruction. And here you see there are multiple air fluid levels. The small gut, small intestine is dilated and it's got multiple air. See, this was the normal, very little amount of air. But when we go here, there's a lot of air, and these are the levels which are known as the air fluid levels. And why this happens? Because when you take the X-ray, the patient is standing, so the air rises up and the fluid is down. So that's why you get this air fluid level. And this is the utility of an erect X-ray abdomen. How does it seen on a supine X-ray? Here the patient is lying down. Again, there's a lot of air. The small bowel is distended, but here you don't see any air fluid levels. So this is the basic thing, the basis of the intestinal obstruction that is seen on a X-ray. And I think at, like my undergrad final year student, he should pick up this pathology on an X-ray. Okay, fine. So we are done with the X-ray. Now we go to the fluoroscopy or the contrast studies. Just let me see if I'm exceeding my time. No, I'm in time. Okay. So the contrast studies are basically the fluoroscopy. So what happens is the machine is almost the same. The principle is the same. It is basically utilizing X-rays, but you are giving the patient some contrast, oral contrast, right? And as the bones have a high atomic number and they absorb more X-rays, similarly, the contrast also has got a high atomic number. It also absorbs the X-ray, so it would appear white. So what's the difference between the X-ray and this study is basically you are doing a real-time imaging. You're asking the patient to drink a contrast, usually barium, and then you are taking the serial images. So you are looking at it in real time. You can see the peristalsis. You can see if there is something wrong with the peristalsis, if there is some filling defect, etc. Okay. So the contrast media that we use, mostly for the upper GI, we use the barium sulfate powder. We dissolve it in water, and then we've got different kind of suspensions that the patient brings. There's another compound known as the gastrographin. It is usually used in post-operative patients. For example, you did a surgery, intestinal surgery, you did an anastomosis, and then you want to see whether the anastomosis is working. If there is some leak from the anastomosis, then you give the patient the gastrographin. And why is that? Because barium is very dangerous. If you give barium to a patient who has got a surgery and the wound is leaking, when the barium enters the peritoneal cavity, it will create havoc and the patient will get a peritonitis. So it's dangerous. That's why for post-operative patients, if we are suspecting leaks, if we are suspecting fistulas, we should give a gastrographin. Then there's also lower or smaller contrast media available, and this is the best because it doesn't, wreck with your normal peritoneal cavity. So coming to the barium swallow, I think barium swallow is the only test we are doing right now, because most of the other, the barium enema, the barium meal, they have been replaced by the endoscopies, right? So the barium swallow, basically the main indication is dysphagia to solids or liquids. The patient preparation, there's none preparation is needed. You can do it as the patient comes. So this is how it looks like. This is the patient. She's having a glass in her hand. She's drinking the barium. And this is the technician or a doctor who's taking the image. See, he's wearing a blue colored apron. And he's also wearing a pink color thing on his neck. So this is the thyroid shield, and this is the, and both of these apron and this shield, they have got this lead inside, because the technician is very susceptible to get radiation from the patient, right? So he has to take care of himself first. So this is how it works. The patient takes a sip, and then you see it on the video, and then you take the images. So this whole tube, this white tube, is the normal esophagus, thoracic esophagus. This is the cervical esophagus. It is a lateral view. You can see the valvuculi, you see the piriform fossae here. This is the APU. So this is how you do a barium swallow. Just a little bit about the achalasia, because it's a common thing. As I've told you before, we are doing these swallows mostly for achalasia nowadays. So basically, what is achalasia? It's where the lower gastroesophageal sphincter, it fails to relax, and it usually there's something wrong with the nerve plexus, the oryvax plexus over there. It's a disease of usually young patients, about 20 to 40 years, and this is how it looks like. As if I go back, this is the normal esophagus. See its dimensions, its width, and when we come here, achalasia cardia looks like, and the lower end is constricted, the upper is dilated. So this is how you see it. Okay, so now coming to the meal. As we know, the meal, what does meal means? We eat the meal and the meal goes into our stomach. So to see the stomach, you do a barium meal. And what are the indications? Vomiting and epigastric pain. But as I was talking before, because of the endoscopy, we don't usually do it. I mean, when I was doing my training way back in 2002, we used to do a lot of barium meals then, because the endoscopy was not in vogue. But now my PG trainees, they haven't, I don't think they have seen a barium meal ever. So because we have our endoscopy, you go in, through the endoscopy, you go inside the stomach, you see it. If you want to take a biopsy, you can take it. So it's the thing. But then again, we should know how it is done. So this is how it is seen. The patient is standing, right? So the air is in the fundus. This is the body, lesser curvature, greater curvature, antrum, and the duodenal bulb. So this is how beautiful. I mean, I really like this image. I really want to frame it and put it in my office, I guess, because it's a very well done barium meal. And another image of the barium meal. So the patient is lying, so the contrast is in the fundus. The contrast is white. Why? Because I've told you it absorbs the X-rays. This is the air in the fundus. And see here, if you can see the two small outpouchings which are filled with the contrast, these are the ulcers. This is how the ulcers look like. And but now we do endoscopy. So coming to the barium follow through. So in follow through, we are looking at the small intestine from the duodenum to the jejunum, ileum, and the ileocecal regions. We have to take the examination till the ileocecal junction. What are the indications? Diarrhea, anemia, GI bleeding, malabsorption, intestinal tuberculosis, which is very common in our country. So this is how a very beautifully done barium follow through looks like. The stomach, you see, this is the duodenum. This feathery appearance is all jejunum. This is the ileum, colon, and here, see, this is the ileocecal junction, which is being magnified, right? So this is how it looks like, and it takes a lot of time. The swallow and the meal, they are done in about 15 to 20 minutes. But as we know that when we eat the food, it takes a lot of time for the food to go from the stomach to the intestine to the large gut. So it takes a lot of time. It takes about 1.5 to 2 hours. So this is a lengthy procedure. Another normal barium follow-through examination, but here the contrast has gone into the colon as well. So it's a very late film. So coming to the barium enema, what are the indications? Change in the bowel habit, constipation alternating with diarrhea, if you're suspecting a mass, if you're having a bleeding per rectum. But then again, because of the colonoscopy, it is usually obsolete now. And then we've also got CT scans for a CA of the colon. We would like to do a CT, but then again, there are, especially in Pakistan, there are places where the CT scan facility is not available, and the doctors who are working in those areas, in the district level and the tehsil level and the villages, they should know how barium enema is performed. So the other three things, the swallow, the meal, and the follow through, we drank the barium. But here the thing is different. You put a tube in the rectum and then you give the enema. Just like an enema, it's a barium enema. See, this is a technician and the patient is lying on his left side. You put the tube inside, you give the barium, then you give the air, and you take the images. So this is how a normal barium enema looks like, very beautifully again. This is the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, and the rectum. And here you see the appendix is also very acutely opacified here. So if there is something wrong, if there's some obstruction, you'll see dilatation. If there's some filling defect, definitely a mass is projecting inside. I didn't want to confuse you because it's the first session. So eventually when we move forward, maybe I'll show you again. So these are just the 3 images because I also give kind of this lecture to my final year students. So at the end of the session, I ask them, okay, fine, what is this? So we know this is a tube, long. So this is a swallow. You see the esophagus. This is the stomach. So it's a meal, but then you see the here the intestine as well. So it's a meal and a follow through, and this is a barium enema. All right. So the X-ray part and the fluoro part is finished. Now we come to the ultrasound, because ultrasound is also a mainstay to see the diagnose the pathologies of the abdomen. And the best thing about ultrasound is there is no ionizing radiation, right? So just to tell you what's the difference between the ultrasound and X-ray, the ultrasound, it uses the sound waves to get an image, and X-rays are electromagnetic waves. So as it is a very safe procedure, hence it can be done in children, in pregnant women. And in my opinion, I think ultrasound should be done in every patient first, and then you should go to the modalities which involve radiation. So this is how an ultrasound image looks like. This is the liver. I don't want you to get confused how to see the liver, because in the beginning, when I started my residency, it looked like something black and gray and clouds and thing. And I didn't know how my consultant is, saying that, okay, this is an abscess, this is a mass. I said, oh my God, I can't see anything. But then again, with the practice and the expertise, you see things. This is the gall bladder. Just for your interest, this black thing is the gallbladder, and black is the fluid. So it is filled with bile. But here you see this white thing. This is the gallstone. And so this is how you do a ultrasound. This is the ultrasound of the pancreas. So this is the head and the body and the tail. This is the splenic vein, and this is the portal vein. Okay, sorry. So again, what is the usefulness of ultrasound? It is very easily available. It's a cheap investigation. It's ionizing radiation free. So the best part is it's ionizing radiation free, but a little bit of pitfall is that it depends on the patient's body habitus. If you've got a very fat patient, you won't be able to see things clearly. And it also depends upon the operator, the person who is doing. So if the person who's doing the ultrasound he's got experience, then he'll be good. But a junior person would take a lot of experience to give you a good result. But then ultrasound is the modality of choice from my side. Coming to the CT scan, so this gentleman, this handsome gentleman is Sir Godfrey Hounsfield, and he won a Nobel Prize in 1979 because he invented the CT scan. So basically, what is a CT scan? A CT scan is basically just like an X-ray, but the difference is that there are in the X-ray, there's only one source of radiation. In a CT scan, there are multiple tiny sources of radiation that crisscross the patient, and you get a 3-dimensional image. So this is how a CT machine looks like. The patient is here. This is the gantry, and in this part, there are small detectors of a smaller X-ray producing areas, and then there are the detectors who detect the X-rays, and you get a 3D image. So what are the indications? You can do a CT scan for everything, but generally you do it in emergencies when you don't have much time, for a trauma patient, and even for an internal obstruction. And sometimes when the ultrasound is equivocal, for example, if a patient comes to you with a suspicion of appendicitis and the ultrasound is equivocal, the labs are not in the favor and you're not sure, so you can do a CT scan to check further. And then you do for malignancy, especially for staging a tumor. When you're diagnosed with a tumor, then you have to go to stage the tumor, doing the T and M, and for that, the CT scan is the modality of choice. This is how a CT abdomen looks like. And this is a anterior part, posterior part. So this is the vertebral body. This is the kidney, right kidney, left kidney, liver. This is the gallbladder, stomach, and this is the pancreas. So see, everything is very clearly visualized. And here, so in CT, the best part of the CT is that the patient comes to the scan, the scan is done within a few minutes and the patient goes home, but you can play with the images, you can get a coronal reformat, you can get a sagittal reformat. So this is the best part. So this is the coronal, it is from front to back. And here you see there's a patient is standing up or lying down. This is the liver, the kidney, the psoas muscles, the urinary bladder, you see the bones as well. And okay, fine. So first, this is known as the axial view, right? And this is the sagittal view. So you see from the side as well. So sorry, this is the backbone, and this is the lumbar vertebrae. This is the uterus, the urinary bladder, some part of the liver, part of the stomach. So you can see a pathology in 3-dimensional, and you can give excellent results based on that. Coming to the MRI, I don't think I would be saying much because we've got an MRI specialist among us, Dr. Saab, who will be talking on number 3, I guess. But just to give you an overview, this is the person who invented MRI. I'm really intrigued by these guys, you know, because I think they do a lot of work. They discovered MRI. Come on, man. I mean, it's a very big thing. So his Mr. Raymond Damadian, if I'm pronouncing it right. So basically, what's difference between the CT and MRI? So the basic difference is that in an MRI, there's a big magnet, and you are getting the images through that magnet. So there is no ionizing radiation. Again, it's a safe modality. And there's different strength of the magnet. Like normally what I have in my hospital is a 1.5 Tesla. Tesla T is the unit of that. And then there are some open MRIs, have you seen, I guess, there's open MRIs with the permanent magnets about 0.2 to 0.3 Tesla. The more the strength of the magnet, the better would be the image. You can also get images on this open MRI. People are claustrophobic. The main thing is that people are claustrophobic into going into this machine. Now the lumen or the bore is very wide. I mean, it's quite wide, so it's not a thing. But still, again, if somebody's claustrophobic, they can do it under sedation. A pitfall of MRI is that, number one, it's expensive, definitely, as compared to the CT, the X-ray, and the ultrasound. It's an expensive modality, and it takes a lot of time. As I told you, for a normal CT to do, it takes about 2 to 3 minutes and you're finished. But for an MRI, even for one small study, it takes about minimum 15 minutes. So 15 minutes to 1 hour, especially if you're giving contrast. So it's very difficult for the patient to lie still. And especially for small babies, because if the patient moves, then the image is degraded and you won't be getting a good image, right? So it is, so for babies and for toddlers, we do the MRIs under general anesthesia, right? So this is the only difference, but I'm also very in favor of this machine. Why? Because no ionizing radiation, especially for women, especially for children and babies. So this is how an MRI abdomen looks like, just like a CT, but certain things are seen in more clear. This is the liver, the kidneys, the spleen. This is the vertebral bodies. This is the chorda equina. This is the sacroiliac joint, and that's it. So as in CT, you get a 3-dimensional, you get a formatted images, the axial view, the coronal view. So you can also do a coronal and an axial in an MRI. So this is an MRCP. Okay, MRI, you have got a lot of software to play with. You can do an MRCP, which is basically a magnetic resonance cholangiopancreatography, which is like an ERCP, but in ERCP, it's an invasive procedure. You put a tube inside the patient and then you go, but in an MRCP, no tube, nothing, no contrast, just a software so that you see all the bile ducts, the intrahepatic. As you see, these are the intrahepatic bile ducts. This is the common bile duct, gallbladder, cystic duct, pancreatic duct. Everything is visible very clearly. It's very good to detect small stones, and it is also good to detect the congenital anomalies of the hepatobiliary system. Okay. Okay, fine. So I'm just coming to the end of my presentation, and just a little bit because for the students, especially because I mean we have got so many modalities, so we're at a loss what to do, what to order when. So just I mean it is tailored for every patient, but it's just an overview. So if you're suspecting intestinal obstruction, you can do for an X-ray abdomen, erect and supine. But for children, please do an ultrasound first, and then if you want, you can do a CT scan to see the exact cause of the obstruction. For GIT malignancies, first, as I've told you, do an endoscopy. If you're suspecting a cancer of the esophagus, stomach, colon, anything, you put the endoscopy, you take a biopsy, but then you do a CT, abdomen, and pelvis for staging. Ultrasound can also be used for staging, but ultrasound can only show you the solid organs like the liver, the spleen. To see the hollow organs, I think you should do a CT. For inflammatory and infective processes like acute appendicitis, acute cholecystitis, acute pancreatitis, pyelonephritis, in other words, if a patient comes to you with acute abdomen, you go for the ultrasound first, and then you can follow it up with the CT if it is required. So my take-home message to you people is that, I mean, the first point is very close to my heart. No imaging can replace a good history and a thorough clinical examination, because now what I'm seeing in my practice, people, they don't even touch the patient, they don't talk to the patient, it just order the investigation, because it's the easy way out. I mean, in very quickly, in 10 minutes, you can see 5 patients. But if you talk to the patients, in 10 minutes, you'll see only 1 patient. Please kindly, the students, I really, I beg you to please do this, do a good history and a thorough clinical examination. And then you have to tailor an investigation, taking into account the age of the patient, the gender of the patient. In children, in childbearing females, try to go for ultrasound first or MRI, right? Because in our country, MRI is not easily available. So I'm talking about Pakistan. For Pakistan, go for an ultrasound. It's cheap, easily available, blah, blah, blah. And then you can go for an MRI. And again, as I've told you, ultrasound is usually the first line of investigation for abdominal pathology. So these are my references. And as I have told you that this is my email address, please copy it, take a pic, whatever. And please give me feedback and ask me questions. And I thank you very much for your patient listening. Thank you.